Next, we're going to hear from Leslee Thompson. Leslee, as I mentioned, is President and CEO of Kingston General Hospital in Canada. And Leslie's got a very different approach to bringing patient-centered leadership to the table. So we're hearing about how do professionals come together and how do patients join with leaders, all to accomplish the triple aim. So Leslee.
Greetings. I'd like to introduce you to Andale McTavish. Andale is one of now 57 patient experience advisors at my hospital, Kingston General Hospital. We're a mid-size academic health science center in Ontario, Canada, and people like Andale have been now, as part of our patient-centered practice, open up meetings, open up forums and speeches like these, help us with orientations in front of residents, in front of new staff. And I offer to you in bringing her voice and her perspective into the room. She would say thank you for being here, especially on the late Friday afternoon of the conference. She would say thank you for participating in the learning that we're about to share of our journey as an organization that's gone through tremendous change. Kingston General Hospital in 2009 was an organization that was in deep trouble. A lot of distress. Government had came and took over the organization and was there for a year. Our finances were bad, our quality outcomes were poor, morale was low, sick time was high. We were a clear organization in distress. So I had the privilege of being offered to come and lead the organization through a change that I knew that the technical side of change would be manageable. The challenge that I anticipated, and it has fulfilled more than my expectations, was going to be the real cultural side of change and to really figure out how we were going to move forward in a way that would truly be sustained in our improvements on all fronts. What's been happening surprised us all. And here's where some of that started. In conversations. I went out and over the course of the first year met with over 3,000 people. I did it myself. I didn't invite any consultants into the process because I knew as the new leader I had to see it, I had to feel it, I had to have the conversations myself with patients, with staff, with our suppliers, members of the community. I talked to everybody. And we began to define together what outstanding care always would look like and would feel like. People started to describe patterns about what they imagined the organization could be, what they wanted the organization to feel like, and the kind of place that people wanted to come and work. But through those conversations, some messages were very hard to hear. Jennifer D. is one of our patient experience advisors who's been with us through this journey over the past 4.5 years. Jennifer, and like other folks in the organization, had a lot of difficulty with one of the experiences that she had. And in fact, there were a number of folks around the time where we were solidifying our strategy that were having literally heart-wrenching experiences. Things had gone terribly wrong. One of the sessions where I was standing with a group of people from the community, a woman stood up and she said, "Leslee, I am afraid to come to your hospital." Afraid. Now, I'm a nurse and a CEO, and there was really nothing that's ever struck me quite the same inside as hearing that. So I thought, boy, we've really got to figure out how we're going to do this change And frankly, we didn't really know how we could make the huge leaps that we knew were ahead of us. It was daunting. So what we did was invite Jenny D., the person who said that they were afraid to come to our hospital, and we invited them into a room and said, would you help us? We've really got so much to do, and we really need your help. So through those conversations, including those with staff and others, the board embraced the aim of outstanding care always. Outstanding care for every patient, every day, always. Now, like most of you in your organization, you've got pockets. We had them too of excellence, but we did not have outstanding care always. We redefined our mission as being a community of people working together to transform the patient and family experience. That became our centering force. Because what we found as we were walking about and learning from others, when I really looked under what was happening in our place, we lost our way. We had succumbed to the many pressures of day-to-day and lost some of the spirit and the focus of why we were all here in the first place. But when we really thought about the mission and thought back to the people that we were talking about and of making it happen, kind of the little light bulb goes off and says, well, but we can't possibly do this on our own. So we invited and said, we need people at the table. What would it be like if we had patients and families at the table a lot? What would happen if patients ran our hospital? Well, a lot of things would change. And then we thought, well, that's exactly what we're trying to do. So we boldly made, at the time of the beginning of our journey, we made the declaration that any decision in an organization, in our organization, where there was going to be a material impact on the experience of patients, a patient would be at the table. Now, 4.5 years ago, I did not have a clue how we were going to do this. Our board said, are you sure? And we said we couldn't be more sure that it's the right thing to do. But frankly, we've got to figure it out. And we're going to figure it out with patients and families with us every step of the way. So we formed a patient and family advisory council at the start with 12 people that were the ones that had probably the worst experiences in our hospital that we had ever had. They came to the table and they started to open up conversations, not just within our hospital, but we opened up those conversations with our community. Now, I'll tell you, my communications leader had a fit because we were out there having our patients who had had terrible experiences talk about what happened to them, but why that led them to a decision to partner with us, what it was like in that partnering, and that was the beginning of an opening up of trust and relationships with the community that we had never had, and with our staff. Because if I went out there and said, this is what we're going to do, it wouldn't be real for a lot of folks. So when the voice of the patient is the voice of change, people's minds start to open. We knew as we were going forward that there are a lot of things could improve. Better communication. I don't know about your organization, but in our place, you can't tell often a nurse from a housekeeper, from a food services person, or a doctor. And people don't wear name tags, or they didn't. So one of the things that the patients did was they said, you know, we need and want a much more professional engagement with our with people, and we want to know who people are. So they came up with the idea around name tags. And putting name tags with big names, your first name, last name, picture, and what you did. Then a patient said, and these were one of many hundreds of surprises, one patient at the table said, well, you know what staff do when they have their name tags? They flip them over. And you know what happens? You know what shows on the other side? Well, typically it's the bomb scare, the fire code, and all of that. And they said, this really isn't very helpful. So we have names on both sides. And it was a patient's eyes that changed that and have continued to change many other things. We've got advisors that are keen to help us see rules and break them in new ways. Simple things, but profound changes, like visiting hours. We now have family presence policies. All of our language starts to change about the affirmative and the asset-based language as opposed to things that we are trying to prevent from happening. Focusing on the positive language, focusing on language that people can understand. The family presence policy, patients participating in rounds, bedside shift changes, not just in front of the patient, but actually involving and engaging patients has been part of the standard of care. New eyes bring new ideas. In the operating room, everyone on the team knows who's going in what the timing is, how things are moving. And one of the patients who was on a tour of the operating room, she says, why can't we have that? And we said, there's absolutely no reason why you can't have that. So now we have kind of like our little airline traffic board without the names, but people know which numbers they are, and they know what's happening in terms of timing in the operating room, and patients love it. They help design it, they've helped deliver it, and evaluate it. We've involved patients in every quality improvement initiative, and in fact, you can't start a value stream mapping exercise in our place. You can't start a major project without having an advisor as part of the team. Because the conversation changes, the perspective changes, and you get to different solutions when you do it this way. We've actually put our advisors through training so that they have some of the same skills as our staff, not to the highest of levels that some of our staff have achieved, but definitely in a way that allows them to feel comfortable and confident and participate in the process. I wasn't really convinced initially that this would be the path to safer care. I didn't really see how we were going to make the distinct link. But we had as one of the platforms of our strategy to eliminate preventable harm. I didn't sleep for a couple of days before we decided to absolutely declare that that's where we were going to go. Again, we had no idea how we were going to get there. But involving and engaging patients through initiatives like this of Save Your Veins and other things started to make change. But then, about 18 months in, we were moving forward, people were excited about the change, and then we had a death of a patient from C. diff, and that was one of my leadership moments where I really I lost it. It wasn't okay. The patient died at our hands. And we had been giving lip service to the things that we wanted to do and change in some of the areas. And while people's hearts and intentions were right, we were still scratching the surface. And so we needed to recalibrate. And I brought everybody in a room not quite as big as this, but with about 150 of our leaders, and said, you know, it's not okay. It's not right. And we've got to pull up, look at where we really are, as well as where we want to be, face the facts of where we clearly are letting people down, and we committed together to make change. So we're letting ourselves down, but most importantly, our patients. That situation was one that then helped move us into a new era of really focusing on the behavior parts of change. So hand washing is a vital behavior in our organization. We now, I'm proud to say, are consistently, for the past 3 years, 95%, every category of staff, every unit, hand hygiene before and after every patient interaction. We have some of the best infection rates, meaning the lowest, now in the province. Our patient advisors were the ones that came up with the poster that was in the front of when you walk into every unit to tell you, as a family member, what the hand hygiene rates were on that unit, so that you would know, you'd be aware, and you could then ask questions. It was setting a standard that they could count on us for. Change is hard, and sometimes you hit other bumps that are unexpected. We changed food services. People said our food was terrible, and it was. We also had huge budget issues to overcome, so we decided to redesign a whole variety of things. And frankly, our patients were part of the process. They participated with us. They helped choose the food. They were on the RFP team. They were part of the process because this was something that was going to affect them. But that was when I also learned, after 3 days of protests outside the hospital, that people can really twist around the notion of patient-centered care. There's a lot of folks who will put everything and say, well, we're being patient-centered, and that's one of the risks as a leader of really thinking about how do you move this forward in a very meaningful way. It's got to be about the proof, not the promotion. And that focus on the proof, the question then is, what as a leader do I need to do to cultivate the trust, the transparency, and how are we going to keep moving forward? What do I do as the leader? What's the role of each of you as leaders in your organizations? So, came up with this notion of patient-centered leadership because I was actually starting to feel a bit left out because everyone was doing their thing and really engaged in where we're going. So started to think about this notion of patient-centered leadership, and we developed a checklist about it. There's only 4 parts. And I want to share this with you today because it's now these 4 domains, parts of a checklist. It's about supporting a leadership behavior set that is now setting the stage and helping to really cultivate and sustain a culture that we've all embraced around patient-centered care. See, include, share, and listen. What do the numbers really mean? How many of you sit in front of spreadsheets and charts and numbers? By having a patient at the Infection Control Committee, she asked one of the big mucky-muck physicians, she said, so tell me how many people came to the hospital this month without an infection and left because we gave them one. That is a whole new way of looking at the numbers. We call it peopleizing the numbers. That's the language that's been introduced in our place. And now reports all need to reframe the numbers. Don't focus on the decimals. Tell us about the people. How many people are in eMERGE? How many people waited for more than 5 hours? How many people died? Not the mortality rate. How many people died at our hospital that shouldn't have this month? It changes the mindset. The second is sharing the stories. We really encourage the spot and share. Spot something good, spot someone doing something that's transforming the experience for patients and families, and share that story. Storytelling shapes culture. It changes the language. When you have a patient at the patient flow task force trying to help get the patient from eMERGE up into the unit, which is something I've been trying to do for 30 years, we still can't seem to get it right. When a patient's there, you don't talk about bed blockers, you don't talk about ALC patients. There's a face to the name, and then the stories about what that experience is helps shape the improvement effort. Every initiative, every policy, every business case in our organization, there must be demonstration that you've included the perspective of a patient in the formulation of that recommendation, that policy. A Patient Family Advisory Council has as much weight as the Medical Advisory Committee. There's no hierarchy. that's when the needle starts to move in thinking and including at every step. We've even flipped the interviews. So we have patients on interview panels for nurses. Our friends from Georgia Regent and here in the U.S. we've partnered with, and they started this, and they told us about it, helped us figure out how to do it, and we started. And now it's a differentiator in our organization because nurses who would get interviewed at our place, they're choosing us because they say, I want to work in a patient-centered hospital, and I couldn't believe that you actually had patients interviewing us. And that's why I chose you, because you have made it real. And that is another element of leadership. The next dimension and question in a patient-centered leadership model is asking yourself and asking others, what have I learned from a patient today? That's a question that I routinely ask on rounds of others, and it's a question that we talk about in our executive meetings and in other sessions. What have we learned from a patient today? Not what I've done to, not what I've done for, what have I done with, and what have I learned, so that then you share the story and the cycle starts again. Patient-centered leadership is about the individual ownership and accountability for cultivating the environment in which the conversations of patients partnering with staff to improve care, to transform the experience, can flourish. We are asked a lot about what are the winning conditions. So some of the things that are the summaries of some of the things that we've learned around how do you actually build this and hardwire it into your culture. I would say that we are not hardwired yet. We're still learning, we're still growing, but I am proud of where we are. I think the most important thing is bias for action. Just do it. We did not have a roadmap. We did not know exactly how we were going to do things, but we knew what we wanted to do, and we set milestones. We set those being defined by quantitative metrics as well as the qualitative initiatives, qualitative things that we knew that we could be headed on the right direction. We tried some things. We learned from them. Sometimes it works. Sometimes it doesn't. But that spirit also of continuous improvement is key. People always say that the strategy and bringing it to life, as well as leadership, is also really important. I think I have learned to appreciate more people's perspective on the importance of leaders from the top, but I've always felt that it's leadership throughout the organization and distributive leadership that's really the power of change in this. Connecting the dots is something that's a really important feature of change. So when we were the first Canadian hospital to win the NRC Picker Patient-Centered Care Award, and we were really proud of it. So the patients, though, the patient advisors were so proud of it, they went around to every unit, day and night shift, to share the award, to say, thank you, and look what we have done. It was so magical because that was a dynamic that never would have happened 4 years ago, and it's one now that perpetuates the kind of mutual pride and conversation that we are having. I think the most important final piece, in addition to some of the minor kind of essential pieces of embedding any change, is keep learning, keep growing, keep sharing. We've partnered with a few organizations together. We have not used big consultants. We've done it, made it up as we go along. We haven't even taken really the time to write it all up. That's something we need to do. But we open ourselves up for others to learn from. And the question probably I get asked the most is around kind of how do you choose your patients and how do you keep it real? And authenticity is absolutely essential. And I have a deal with every one of our patient advisors that if they ever feel that they're being co-opted, if they ever feel like they are being put in a position of not being able to tell the truth, to provide their own experience, to use their voice, no matter how difficult the circumstance, that's a time where we come back, we've got supports, we're always going to have check-ins, but there's a natural tension in this, and that's okay. And we have, every committee has a patient on it in our organization, and we are just launching, moving to the next level of a patient on our senior management committee. But the real work is at the front line, and that's where the difference is made the most. And it involves everybody in the organization. It involves the community, the patients, the learners, and one person, one interaction at a time, we're finally really changing. We started with headlines that were about how awful we were and how KGH was a classic example of everything that could go wrong in a hospital. And we were the poster child for what not to do. A short 5 years later, we were on the front page of the Globe and Mail, which is our Wall Street Journal, our big newspaper, with a reporter who did a front page above the fold article on the patient experience advisors at Kingston General Hospital and how they were partnering to fundamentally change the paradigm of thinking and the face of healthcare. That not only through the work we're doing day to day, but how that is helping to be spread to other organizations as an example. We are so proud of where we are, what we continue to do, where we're learning. We've got a long way to go, and I'm so inspired by being here at this conference to keep on learning and keep trying new things that I've learned that I can take home. My ask of you is that you think about your leadership, patient-centered leadership, no matter what role that you have, to share, to see, to learn, and to lead in a way that is truly, truly patient-centered. Thank you very much.